I'd like to welcome Dr. Bill Stell to the podium, or as we like to call him, Dr. Bill. Dr. Bill is a professor of cell biology and anatomy at the University of Calgary. His research focuses on how the retina controls eye growth and how to prevent myopia. As Foundation Fighting Blindness Director of Research Programs, Dr. Bill works to expand vision research in Canada, encouraging both his students and his scientific colleagues to engage in research on retinal degenerative diseases. Dr. Bill will speak about emerging neuroprotective treatments, which may slow the loss of vision for people with retinal disease. And with that, I'd like to welcome Dr. Bill Stell.
Erin, thank you so much, and thank you all for being out here today. Well, neuroprotective therapies are, if you'll pardon me for oversimplifying, neuroprotection is the aspirin of retinal degenerative disease. The whole idea is not to have to deal with the underlying genetic disorder, but to prevent it from doing bad things. So here's kind of how it works. Neuroprotection is basically, let me give you an analogy. I like to use automobiles as an analogy. And what happens here is that it's as if somehow you got sludge in the fuel tank of your automobile. Now, the fuel tank is still there, the automobile still runs just fine, but if that sludge gets down the fuel line and into the engine, it gums things up and the car stops. So what do you do for that? Well, you don't need necessarily to get a new car, you just need to get rid of that sludge. So you put a filter in the line, or you draw off all the gasoline and put in clean gasoline or something like that. So really, that's something that you can all understand. Almost all of you have driven or drive an automobile, and you have some idea how they work. So now you're just as expert as I am, because you know that neuroprotection is just like cleaning the gasoline in your gas tank. Wow. So it really, neuroprotection is based on the idea of introducing something into the body that prevents a damaging mutation from causing cells in the retina to die. It's really that simple. Now, this means that it's largely a kind of therapy that's directed towards dominantly inherited diseases. Because in dominantly inherited diseases, for example, the most common form of RP, which is autosomal dominant mutation in the rhodopsin gene. Does anyone here have that? You might, or you might know somebody who does. So the rods that contain the damaging mutation in the rhodopsin gene, you remember that rhodopsin is the visual pigment in the rod photoreceptor cells. They go on functioning just fine for a long time, but gradually over time they go downhill, and finally they die and disappear. And the person who has that mutation has autosomal dominant retinitis pigmentosa. Now, it mystified scientists for a long time that this could even be so. You've got this mutation that makes you go blind, and yet you can see for a long time. And about almost 30 years ago, when I first became associated with the Foundation Fighting Blindness, it occurred to us even then that one of the best strategies for dealing with RP would be not necessarily to cure it, but just to prevent it from robbing you of sight, or at least to slow down the loss of sight. My goodness, who wouldn't be happy to be able to see better longer? you know, if you can forestall that final devastating end, there's a good chance that there will be some better therapy down the road. So this is where we are. A variety of therapies are being developed whose goal is not to cure the problem in the gene itself, not to replace the bad gene with a good gene, but just to prevent the bad gene from doing the damage that eventually results in loss of sight. So one of the therapies is based on directing drug treatment or gene therapy towards the ultimate process of cell death. Now, this process of cell death has a fancy name. It's apoptosis, or some people don't pronounce that P in the middle, and they call it apoptosis. It comes from Greek words that mean lopping off the tips of things. And a long time ago, scientists noticed that some cells, when they're dying a certain way, shed little bits and pieces. Just like a tree sheds its leaves in Edmonton just about this time of year. So apoptosis is a controlled process of cell death that can be triggered by, among other things, certain kinds of mutations, making proteins that are abnormal. The cell monitors itself. All of our cells all the time are monitoring themselves to make sure they're doing the right things. And just as we want our bodies to reject cancer cells because they're doing the wrong things, sometimes other kinds of changes take place in cells, and the cell has ways of recognizing that something's not right and getting rid of itself. It's a sort of cell suicide. So what we want to do then, and what scientists working in this area are trying to do, is to prevent cell suicide. You've just heard Dr. McDonald mention this morning that a team here at the University of Alberta is using an experimental model. That's an animal that mimics a human condition, the zebrafish in this case, to develop a drug therapy to prevent cell death in this animal mimicking RP. Another effort that's being supported in Canada is being carried out by Catherine Tsilfidis at the University of Ottawa. Dr. Tsilfidis is really going for the heart of it. She's devised a way of using a normal biological mechanism, something that our cells are capable of all the time, to prevent that final step of cell loss by apoptosis. And she and her collaborators discovered about 10 years ago that a protein that can be made by our own cells, but normally isn't made in large amounts, called the X-linked inhibitor of apoptosis, XIAP, which we say ZIAP because it's a lot easier than saying X-linked inhibitor of apoptosis. It's possible to induce cells in the retina to make more of this than they would normally make by inserting into the retina genes that are carried by a viral vector, which gets cells to take up these foreign genes and then to express them. And what that means is that the cells that take up this extra ZIAP gene will make extra ZIAP protein, and that will inhibit the tendency of the diseased photoreceptors to die. This effort in Dr. Tsilfidis' lab, supported heavily by the Foundation Fighting Blindness in partnership with the Canadian Institutes of Health Research, is well along. It has been tried and proven in several different animal mimics of retinal disease, and it works, and it's safe, And the plan is within just a few years to begin the first human trials. So that's something that you can be looking for that comes from FFP-supported research right here in our own country. Now, some of the other, I'll just give a brief list, and you can find information about all of this on the FFP website, because thanks to the wonderful Lori Lyons, who is our science officer and writer, we now have on the website up-to-date, authoritative, easily readable and understandable summaries of what's going on in RP and related disease research. So you should go there for further details. So a quick list of some of the things that are being studied is there's a thing called TUDCA. It's not even a good acronym. It's not something that rolls off the tongue. TUDCA. It's really a shorthand for a chemical name for something derived from bear bile. In China, the gallbladders of bears are thought to have magical medicinal properties. And as is often the case in folk medicine, there is actually something to that. So one of the components of bile in bear gallbladders is neuroprotective. And so this is being tested in human clinical trials starting next year, I think, in the US. Some Italian scientists are developing and testing a drug called miriocin, and maybe who's Italian here? Any Italians in the group? No, then I can get away with it. I'm going to pronounce it the Italian way. Miriocin, that has been found to slow down cell death in animals. There's a thing called encapsulated cell technology, ECT. The company that makes this has programmed cells to make a protective factor, which is called CNTF. I won't bother you with what that stands for. And the cells are protected from loss or destruction by putting them inside a tiny capsule. It's almost like a miniature gelatin capsule that you might remember once upon a time getting medicines in. And it keeps the cells in, but it lets the CNTF that they make go out. So this capsule is implanted inside the eye in a simple, relatively minor operation. And then for months or years, those cells continue to perk away, producing the factor, which gets out into the eye and into the retina, and in principle should help to protect against cell death. And that's now in phase 2 trials of 120 people with RP. And there has been some benefit to this, but as those of you who have RP know, the progression of RP is fairly slow in most cases, and so it really takes years to assess whether a treatment is beneficial or not. But there's certainly good reason to hope for this one. There's research in France on a thing called rod-cone viability factor. You know that in RP, the rods tend to die first. They die first because they're the ones who are affected by the mutations. But for some reason that is still not perfectly understood, eventually the cones also, the cone photoreceptors also die and disappear. And it's been speculated for a long time that this could be because the rods the normal rod photoreceptors produce something that protects the cones and sustains them. And you take away the rods, then the cones are starved and die as well. So there's an approach to treat that. Other things that you might have heard of are valproic acid, which is an epilepsy drug. This is now being tested in another animal model, a zebrafish with that mimics human autosomal dominant RP by I'm blocking on his name, in Vancouver. There's a glaucoma eye drop called uniprostane that is aimed at protecting the retinal cells that transmit messages to the brain in glaucoma from cell loss. But if it can keep those cells from dying, then it ought to be able to keep rod and cone cells from dying as well. So that's being tested. Now, so to sum up, the advantages of protective therapies are, first of all, that they're not particularly specific. That is, they're not specific to a particular gene or a particular mutation that causes degeneration. And so they should be useful for AMD and for any RP or RP-like disease, as long as it's caused by a dominant mutation. The disadvantages, on the other hand, are that they are like an aspirin. They don't address the cause of the disease, but just mitigate its effects. That's not a bad thing, but basically you should understand that the underlying disease is still there. And ultimately, we would like to get rid of this. It is really a good idea to slow down the progression of the disease if we can, because as I mentioned at the beginning, there's always a good chance that research is progressing so rapidly that this can maintain vision until a better solution is available. And finally, I've mentioned that that neuroprotective therapies are, in principle, useful for dominantly inherited disorders, but they are probably not, in general, useful for recessively inherited disorders, because recessively inherited disorders are due to a loss of function of the gene. That is, the gene doesn't make something that is essential. And so this is like taking the gas out of the car completely. And the only way you're going to get a car to run, if the gas has been taken out, is to put back the gas. So for recessively inherited disorders, replacement of the defective gene is, so far as I can tell, the essential way that therapy can be provided. Fortunately, that, not at all the topic of this session, but there's been tremendous progress, very rapid progress in that area. And in fact, it's moved ahead much faster than therapy for dominantly inherited diseases. So progress is good for all kinds of disorders, including the recessively inherited ones. So that's what I have to tell you to get things going. I hope you have some questions, and I'll be glad to answer them to the best of my ability. Thank you.
I do not have the disease, but my husband and sister-in-law do. I was to an optometrist for my own glasses that I needed, and I got talking to him about RP, and I asked him after the death of the retinal cells if there was anything yet that could renew vision, but he said that the optic nerve, because it's not being used, also dies, and that's the problem. That even if the retina was helped, you have to deal with the optic nerve. I didn't really understand that.
Okay, I think what he's told you is partly true. When the rods and cones die, in rod and cone disease, then the next nerve cells that they normally send messages to within the retina to do the processing of visual information, they can change, for sure. And eventually, over a long time, over many years, it can be that the cells in the retina die away. So a replacement therapy or a neuroprotective therapy Certainly, the strategy is to treat as early as possible. But for a long time, after the first symptoms appear in a retinal degeneration due to a genetic mutation that affects the rod and cone photoreceptors, the rest of the retina still can be alive and reasonably well for quite a long time. This is why we talk about using replacement cells, newly generated rods and cones derived from stem cells, which Dr. Shermans is going to talk about later today. If the rest of the retina were not healthy, then there would be no point in putting in new rods and cones. The same is true with all of the other replacement therapies. The electrical prostheses that Dr. McDonald mentioned briefly as well. So no, I think that your optometrist is correct in a sense, but unnecessarily pessimistic. And there certainly is plenty of reason to expect that replacement therapies, restorative therapies that can give back some degree of vision even after it's been lost, these kinds of therapies are definitely going to be useful and are going to be widely exploited for diseases that cause loss of function or loss of cells in the photoreceptive rods and cones. So it's not so gloomy as that.
Question around, like, people have done some amazing things with, for example, in vitro fertilization and transplantation of cells from one human to another human and so forth. It may not be directly in line with the line of research you do, but what are the odds of taking, or the ability to take, rods and cones and transplant them from one human to another or one animal organism to another?
Well, of course, to take adult cells from one individual to another is a pretty dicey business. First of all, if it's from human to human, there's a problem of finding large numbers of sources of donors. You can't give away pieces of your own retina without losing something. So I don't think that particular strategy is going to take hold very well. You know, you wouldn't give up your hand so that someone else could have a hand, probably. It's not quite the same as giving away a kidney when you've got another that takes care of the whole function. But the idea of I think the best possibility, and I'm not going to say much more about this because that's Dr. Sherman's expertise, and she will tell about this this afternoon. But I think that to derive new rods and cones, rods or cones, from undifferentiated pluripotent cells that can become anything if you provide the right stimuli, that's definitely a good therapy. It's being developed rapidly by many labs around the world, and it has been shown that some rods and cones can be transplanted into the retina that's missing them and can take hold and provide some restoration of vision. And so listen to Dr. Shermans this afternoon, and you'll get all the details.
I have a couple of questions. First, you mentioned many drugs. Is any of the drug is out yet, means approved by FDA or Canada, Health Canada, or likely to be approved? And my second question is that you said that we can use gene therapy to insert those factors or genes which are responsible to slow down apoptosis. That if tomorrow I find that what's my gene actually the mutated, can we do gene pyramiding, something like that, to insert my gene to correct the original one?
Okay, I'll address your second question first. I think the question was, can gene therapy replace a bad gene? Is gene therapy possibly a way to deal with dominant inherited disease? The answer is yes. This has been done on a small scale in the test tube and in experimental animals. It is a more complicated problem, and because of that, it's running behind gene replacement therapy, which is what we usually mean when we talk about gene therapy these days. But unquestionably, in principle, it's possible to develop therapies that seek out a particular mutant gene and inactivate it or remove it, and then to replace that with a normal gene. This, in principle, can be done. And I can virtually guarantee that within the next 5 or 10 or 20 years, there will be therapies ready for testing along these lines. Now, the cost is a big factor. These kinds of therapies that we're talking about are, at present scale at least, very expensive. As all therapies and all mechanisms are when they're in the very initial small-scale stages of development. We've really got, at this stage, almost personally targeted therapies. And what makes it really expensive is that the development of the means for inserting new genes into the retina takes a very long time. Once the therapeutic agent, the vector, has been created, it needs to be generated in large enough amounts that there's enough for all the necessary treatments. And there are terrifying and really important concerns about the safety of those agents. So it can take, 2 or 3 or 4 years to develop therapeutically useful and safe certified quantities of the agents for this. I don't know what the dollar costs are exactly, but really for any of these therapies at this time, they're enormous. They're in the at least the tens to hundreds of thousands of dollars per person treated. That's going to change a lot once something is generated that is made in significant amounts for generalized available treatment. But it's always going to be an expensive kind of thing, I think, because unfortunately our family of diseases is relatively rare. The number of people who have RP or similar diseases, it's small compared to the number of people who have the biggies: cancer, heart disease, stroke, even other genetic diseases like cystic fibrosis. You know, the numbers there are huge compared to the numbers with RP. So it's really hard to predict how the costs of these kinds of therapies are going to be handled in the long run. They are probably going to be more expensive than the current therapies for AMD with anti-VEGF agents, which run on the order of $10,000 to $20,000 a year per patient, ongoing for many years. That's not deterring us from doing research to understand what causes the particular mutations to cause blindness. It's not going to deter us from developing therapies. As scientists and as a charitable organization, the FFB, our job is discovery and creation of hope. And that's what we're doing. So we'll leave it to the politicians and economists and business people to deal with the problem of cost. But I'm confident that when it's clear that there are deliverable therapies that are really creating improvements in people's lives, that a way will be found to make them available. We have to believe that, and I do.
Hello, Dr. Stell.
Hi.
Thank you very much for coming again.
Thank you for coming. Thank you for coming up here and speaking to us. It was very inspiring.
Oh, I really appreciate you very much, all you scientists and researchers. My question for you is, a few arose while you were speaking. I had a daughter when I was 18, and I gave her up for adoption. When we reunited for her 28th birthday, I told her that she better get her eyes tested because her mother is a carrier of RP, Usher syndrome. She went to the French ophthalmologist, and they said, oh, well, you don't need to worry. We can take care of that, even if you did have it. So, 15 years ago, she told me that, Mom, you don't have anything to worry about because the French doctor said there's already a cure for that. And I heard Dr. Ian McDonald say that you work internationally. And so that's a good thing to hear, that you are working together. Yes. Worldwide, because, we Canadians don't want to miss out on anything. And I'm very glad that you're working together and that you're on top of this. My second question would be, well, that wasn't really a question. I was just to let you know what people always say, oh, well, there's a cure for that. And they don't understand that, no, RP is different than other eye conditions, right?
Right. Well, may I make a quick comment on that before you go on to your second question?
Yeah.
It is unfortunately true, and I mean nothing bad about the eye doctors, but it's unfortunately true that some eye doctors are not up on the fact that therapies are possible and are being developed. And I would almost guarantee that some of you here have been to an eye doctor sometime within even the past 10 or 20 years who has said, I'm sorry, you have RP, nothing we can do except to track its progression. Bye. So one of the best things that you folks can do is to educate the doctors. Mm-hmm. And go back to them now. Go to their office now while it's still fresh in your minds and say, hey, I just went to this wonderful conference and heard how much research is going on, and there are actually clinical trials, and you, doc, go to the FFB website and find out what's going on. What's your second question?
And I've done that. I've taken FFB's newsletter into Dr. Ian McDonald the very first time I met him. I said, read this. Is this true? Read this. What's all about this, vitamins and stuff like that? What's that all about, Do you know about that? And so he did, and he got the pharmacy to give me a pamphlet on the, omega-3s and vitamin Ds and stuff like that. So that was really good to know, and if I didn't advocate for that, I wouldn't have known that. If I didn't have that newsletter from Foundation Fighting Blindness, I would not have been kept up to date on what's going on. So I'm really trusting that I'm going to be kept up to date by FFB on what the scientists and researchers and everybody's doing around the world.
Can we sign you up to speak at the next Vision Quest?
Okay. Well, my second one was, did you mention that there were oral drops that you're developing right now? Are they available, or is it a funding problem with the government? Is it out in phase 2? Or?
I don't have the particular details. You'll find them on the website in our news summaries that Lori prepares, and also through the U.S. clinical trials site that Dr. Mack mentioned.
Okay.
But the simplest answer is no. There is no such there is no treatment available now for RP that you can just walk into the eye doctor and ask for the treatment and get it. And the real bottleneck, the two real bottlenecks are time and money.
Yeah.
It does take time to develop things, and the costs are appreciable. So the best you can all do as individuals is to understand that time is necessary, and as hard as it is, to be patient, but at the same time optimistic, because you know that help is coming down the road. And second, to do everything that you can to support the FFB and the Canadian government agencies that support eye research with much greater resources than the FFB has. So that's particularly the Canadian Institutes of Health Research. And you can write to your member of parliament and tell him or her that you want better funding for eye and vision research through the CIHR. You know, I work in, as you heard in the introduction, my own personal research is mainly in the area of myopia, nearsightedness, which doesn't rob people of their sight, but which is expensive. 25% of Canadians have a myopia and good vision, but it still costs them maybe $100 a year on average for examinations and eyeglasses, and that adds up to close to $1 billion just for Canada for this simple thing, myopia. That's all the money that the CIHR has for everything.
I am good.
So push your lawmakers.
Thank you very much.
To support more money for research.
Thank you.
Thank you.
Thank you.
I have RT. I was diagnosed this summer by Dr. McDonald with it. And over the years, I've been transferred around a lot, and I've been to a ton of optometrists over the years, and including I had eye surgery on my eye that I have RT with. About 4 years ago, I had cataract surgery, and not one optometrist, and including the eye surgeon, diagnosed me with RT or RP until this summer. How difficult is it for an optometrist to diagnose that disease or that disorder? Because I find I'm not as troubled that I have it. I'm more troubled in the fact that I wasn't diagnosed with it earlier, and I just don't know how easy it's to diagnose.
In principle, it should not be that difficult, but if you've gotten this far in your life and just had symptoms severe enough to be bothered by them, it's quite possible that it wasn't detectable before this by anyone. But there's also another factor, and it relates to what I said about doctors earlier. Eye doctors, both optometrists who are mainly concerned with refraction and correcting refractive errors, but even ophthalmologists who are physicians trained to specialize in eye disease, most of what they do is not related to RP. And they may see a case of RP once a year. So they don't focus on it. It's not the first thing they think about. It's probably something that most of them aren't really up to date on. It's, in a sense, it's not their fault, but they could do better. So once again, educate your doctors. For sure, you're more educated about RP than most eye doctors are.
So I'll keep it quick. You mentioned about using drugs to slow down the apoptosis. I've been reading, isn't that also the process that is used to destroy cells when they become cancerous?
Yes.
So couldn't there be side effects potentially there?
And especially for the ZIAP therapy that Dr. Sulfidis is doing, that has been a particular concern. But very fortunately, in the eye, in the retina, in general, all of the cells in the normal retina and even in the RP retina are not in the act of making new cells. So if they're not in the act of making new cells, then stopping cell death isn't going to cause an overabundance of new cells. So it's not going to cause cancer. And in extensive preclinical tests with several different kinds of mice and rats, there has been wonderfully no hint of cancer developing with the ZIAP therapy. So at least for that particular therapy, I think we seem to be safe. But of course, it's not over until the fat lady sings. And she hasn't sung yet.
Dr. Stell, in relation to gene therapy, I'm just wondering, when you take a virus and you neuter it and then you replace it with healthy genetic material, what is the source of that genetic material? Okay, so for gene therapy, a replacement gene is made in the test tube. We know what the structure of the gene is. We know how to spell it. So it's, in effect, the chemical equivalent of typing out a long name. And all of those pieces that make up DNA are strung together in a chemical way, and then they're combined with the virus. Now, since you've brought this up, I'd like to mention that the virus that's used for gene therapy is highly modified from the viruses that we get that causes flu and so on. So it's used only to trick cells into taking in the gene, but it doesn't multiply. It's engineered so that it can't multiply itself. And it's engineered to remove anything that would cause disease. So it's really not anything like a disease-causing virus, and it's safe. And that's it. Thank you very much. I look forward to having a chance to talk with you at break.